overview of the trial. It was a randomized controlled trial using patients 18 years or older who had moderate to severe plaque psoriasis for at least 6 months and were candidates for systemic therapy or phototherapy. Patients were ineligible if they had a history or current signs of a severe, progressive, or uncontrolled medical condition, or if they had current or a history of malignancy, except non-melanoma skin cancer within 5 years. Patients could also not participate if they've used any of the drugs in the trial previously.
There were 3 legs to the trial. Leg 1 was placebo at week 0, 4, and 12, then a crossover to glucosamab 100 milligrams at week 16, 20, then every 8 weeks through week 48. Leg 2 was glucosamab 100 milligrams at week 0, 4, then every 8 weeks through week 48. And leg 3 was adalimumab 80 milligrams at week 1, then 40 milligrams every 2 weeks through week 47.
They graded the severity and improvement of psoriasis using many regional psoriasis measurement assessments, such as the Investigator Global Assessment Score, Psoriasis Area and Severity Index, Fingernail Physician Global Assessment, and Dermatology Life Quality Index.
The end result was that guselkumab demonstrated superior efficacy compared to adalimumab and placebo and was well tolerated in patients with psoriasis through 1 year.
So according to the 2016 addendum to the Canadian Guidelines for Management of Plaque Psoriasis 2009, the only 2 biologics currently listed for use in plaque psoriasis therapy are ustekinumab and adalimumab. Interestingly enough, guselkumab is listed under Future of Psoriasis Care, and a study which references our study is discussed in the guidelines. As biologics are up-and-coming drugs, we feel that with time, biologics will have a greater impact on guidelines and reviews.
Alright guys, so we should talk about some advantages of the study. So patients were randomly assigned to groups using a computer-generated system, decreasing any amount of selection bias.
Double-blind trial with blindness was maintained by using matching placebo.
The dropout rate was around 10%, which isn't as great as 5%, but it was still less than 20, which is satisfactory. The reasons for dropout were all accounted for.
There was a clear description of how psoriasis was defined using overall psoriasis, regional psoriasis, and health-related quality of life assessments. This is good for those interpreting the trial since it allows for a clear representation of the patient's conditions at baseline.
All researchers' involvements were also clearly disclosed at the beginning of the article.
The demographic and disease characteristics were comparable across treatment groups at baseline to allow more appropriate comparison between the patients.
Total trial size of 837 patients is quite large. This decreases the chance of any random error.
So there are also some disadvantages as well, so let's talk about those. The study was completed using 81% adult white males as test subjects. Thus, it is difficult to conclude that other populations like women and other races would have the same outcome.
The placebo group was also considerably smaller than both of the intervention groups.
The study was also supported by Janssen, which is the manufacturer of guselkumab, which could lead to bias.
The trial was performed on patients who had no other medical conditions, therefore limiting the external validity of the trial.
There was no indication of who managed all the collection of the data and who maintained the trial database in a blinded manner.
Patients were able to inject the medication themselves at home or have it injected by a healthcare professional. Therefore, participants did not come into contact with healthcare professionals in equal amounts, possibly affecting the amount of follow-up people in each group received.
Okay, so to conclude, despite there being some unclear points of possible biases, we feel that the advantages of this trial outweigh the disadvantages and proper disclosures were made. The efficacy of guselkumab seems to be best applied to white adult males with moderate to severe plaque psoriasis with no history of or current medical conditions, thus demonstrating low external validity. The information in this study could be applied by clinicians and practitioners to patients that fall within the category of white adult males. However, further studies would need to be done on more diverse populations to increase the external validity of the trial.